Hi, everyone. I'm Darlene, and I'm the Director of Research and Evaluation with Mindful You. I'm also the primary instructor for the assessment courses that we offer. For those of you who aren't familiar with Mindful You, we are a social enterprise consisting of neurodivergent staff with a shared goal and mission of improving the quality of care for individuals in our communities across the globe. We're actually an international enterprise. So we offer a number of training options for licensed clinicians or pre-licensed clinicians who are working on their hours so that they can better support individuals for whom maybe their training program didn't offer much information or who are on waiting lists for assessment. And we do know through research that assessment does lead to better therapeutic outcomes because therapy is not one size fits all. And in fact, some therapies can actually be harmful if they're not the right fit. So that's something that we're trying to pass along. Also, research has shown that an assessment, if done well, is equivalent to 20 sessions of therapy. And so our mission is to share as much information as we can within our limited resources. So we have a range of opportunities for trainings, starting from a very affordable independent study foundations course all the way to a very comprehensive, including weekly live group coaching training program across neurodevelopmental assessment. So my goal during this training today is to share a little bit of information about RRBs, or Restrictive Repetitive Behaviors. For those of you who aren't completely immersed in the field of neurodivergence, this might be new for you. For those of you who are, or you've just entered, great, welcome. My goal is to present you with a few considerations that maybe you haven't thought of before. So, one of the reasons why we want to promote this area is this often leads to underdiagnosis or misdiagnosis, especially for individuals who are female or who come from an underrepresented ethnic, cultural, or linguistic background. Quite often, when an adult presents for assessment, they come in with an assortment of labels. Obsessive compulsive disorder, eating disorders, and Tourette's are just a few of those. Now, this is complex, and assessment is never binary. We never say yes or no, you have it or you don't. We complete what's called a differential diagnosis process, and that's what our trainings aim to teach. All right. So, part of what you need to do as an assessor is parse out what is co occurring, what is the cause of the presenting concern, and what might be mimicking. All right. So, here's a little bit about restrictive repetitive behaviors, RRBs. There are a number of assessments out there for this. Some are more psychometrically robust than others. I'm going to be sharing with you one that you can experiment with. And I would say its psychometric properties are somewhere in the middle. All right. You might find some things online. This one has a little bit more robust, rigorous properties to it. They're still updating it in the research process at Cambridge. So have fun, play with it, use it to further your work with your clients, but also your understanding too. Okay. So you already now have been introduced to this idea that not fully understanding RRBs can lead to misdiagnosis and contributes to underdiagnosis or misdiagnosis. We're not recognizing people or we're mislabeling them, all right? So RRBs are complex. I'm just going to introduce them in terms of about 6 areas, all right? But I don't want you to just limit it to those. This is just an introduction. So first is interests. Does the individual have very narrow interests? Now, of course, we have to take culture and age community, all of that into consideration, because a 16-year-old playing a lot of video games does not in and of itself indicate that they have restricted interests. All right. So we have to look at how impactful is that on the individual's life. Does it bring them joy, but they can separate from it as needed and still go on about socializing or eating out or hanging out and the things that they enjoy, if those are the things that they do enjoy. So we have to look at the functionality and impact, right? But restricted interests. Now, media, television, they've all done a horrible job of creating these tropes and stereotypes of what someone who is neurodivergent looks like. Let's be honest, a lot of the shows that you may have watched were quite humorous. They're presenting though someone who has really limited communication skills, is not very charming to be around, and has a very narrow focus. We might even see representation of kids who walk around with zero eye contact, flapping their hands. And that is not exactly accurate, because you meet one neurodivergent individual, and guess what? You've only met one neurodivergent individual. So do inquire about interests. For some people, it could be a genre of music, K-pop, or a genre of film, or a type of literature, or a very specific type of animal or pet. All right? Knowing all the facts, all the details, the history, the breeds, the colors, that kind of in-depth interest to the exclusion of other things, and not really being interested in expanding their time and investment to learning about other things. All right. So there's kind of this exclusionary piece to it. Another area that we look at for RRBs is routines. Does the person become frustrated or dysregulated if the plans for the day change? That's one that we commonly see with adults, even. And we often think and limit our idea of inflexibility to routines as I must eat this first before I eat that, or I have to brush my teeth before I put my shirt on. Absolutely, it could include that, but sometimes it's subtle. It's not somebody having an all out tantrum about it or falling to the ground crying, because this happens across the lifespan. And so it could be that someone just becomes on edge, dysregulated, moody, not having fun anymore, because the plan was to stop at A, have lunch at B, and then watch the sunset. And B, where they were going to have lunch, was unexpectedly closed. How does that person manage that type of disappointment and change? All right, that's something to consider. People generally feel better when their day is structured overall. Even people who like spontaneity and to have fun, we all have kind of this idea of a structured day, things we do in the morning, things we do before bed. But how tied and connected are people to it, and how do they manage when they can't have that routine or it gets interrupted, especially without advanced warning? That's something to think about. There's a little bit of a my way or the highway element to it. All right. Motor movements. As I mentioned, the trope, unfortunately, is the young boy walking around flapping his hands. Yeah, you probably will see that from time to time in individuals. Everyone's different, but there can be more subtle expressions of this particular RRB when it comes to motor movements. You might find what I call air violin or air guitar, just very subtle movement of fingers. Sometimes it's air typing, and the person could be repeating a word that they're retyping over and over. They're not even aware sometimes that they're doing this. It could be very subtly tapping or rubbing clothing to soothe. So you'll see hand on the leg of the pants, maybe, especially if a situation becomes challenging, or kind of up and down with both hands. Sometimes it's something that we're familiar with, like twirling hair, playing or pulling eyebrow hair. And that's sometimes where people get confused a little bit. There's a fuzziness between this as an RRB and looking at obsessive compulsive disorder. So this absolutely, when we start to look at these types of behaviors, they should be considered in the context of an RRB as well. That's part of the differential we should be doing. And by expanding your knowledge beyond OCD, then you might consider this too. Okay? Speech. Speech could include in the young child humming. You probably have heard of echolalia, repeating a phrase. Maybe they've heard this in the movie and they repeat it often. Scripting, where instead of spontaneous communication verbally, the individual has a very scripted approach to communication where they kind of, you will start to notice after an expanded amount of time together, their responses are the same. They're not spontaneous and they don't change. There's a lot of repetitiveness to it. Okay. They've heard that somewhere. Maybe their parents said that and now they're in the 30s or 40s and they're still saying it without pausing, going, I'm saying the exact same thing my parents said, and I use it all the time. I should vary up my language. That's something to think about. It could be in speech that there's made up jargon, all right? I won't go into the terms for these, but just for you to be aware that sometimes it can include this made up language too, all right? Enjoying rhyming or creating rhymes to the things you say, that might be something as well. Compulsions. Again, this is where things get blurred between obsessive compulsive disorder and neurodevelopmental differences such as autism and ADHD. It's something that you need to suss out. A lot of individuals will first receive a diagnosis of obsessive compulsive disorder. You'll find out that the medication or the therapies for that didn't work. And hopefully later on in life, it's discovered that they more accurately are neurodivergent in a different way. They might be autistic. So that's just something to keep in mind. Of course, not everyone who has a compulsion is autistic or has ADHD, but that's one of those things we want to suss out. We want to look at, again, how limited it is, how pervasive it is. Does it provide some soothing, or is it this obsessive, I must do it, or negative things might happen? And there's a bigger framework from which we look at that, where we, again, suss that out. So be aware of that compulsive behavior. And self-injury. I have heard a number of clinicians, generally who are practicing counseling or therapy, come across an individual and they're very confused because they're interpreting what the individual does as self-injurious behavior. It could be with food in the way of eating disorders, but sometimes it's not. It could be the more traditional self-injurious behavior like cutting or banging one's head, hitting oneself, scratching, any number of things, okay? So just be aware of that. The realm of self-injury is broader than what you may have previously known or thought. And so you should consider that as well. These areas will be on the freebie assessment that you receive. So the other thing to be aware of, and this here is really what's going to separate you from someone who's not familiar with this or just learning about this, is that restrictive repetitive behaviors aren't necessarily always seen. All right. As people become older or more self-aware, or especially in the way of how people are socialized, they're just aware that they need to not stand out. In particular, girls are raised in that way. And women, girls, incredible burden to not stand out or disturb anyone else's peace. So they're going to be a little bit more socially aware to the fact that this is something that I should do in private, or I should find myself a soothing, restrictive, repetitive behavior, or an activating, when I'm feeling kind of low and unfocused, and activating RRB that's not as obvious. And so in these situations, it could be that you're only going to find out about it through interview or an assessment. It could be a certain type of stretch, something that looks pretty typical, could be um, kind of like a type of thing, or one that's common is a tensing of a muscle, relaxation, tensing, relax, tensing, relax. Could be even while you're sitting down, your glutes, your upper arms, anything like that. It's hidden. Some people will intentionally hide. And we see this with tics as well, motor tics. But let's say that somebody has to go to the restroom in order to let this out. Sometimes it can happen with RRBs too. Could be a loud squeal, for instance, when there's a lot of excitement. As the individual gets older, more socially aware, they realize, I still have the need to do this, but I need to do it in private. Or I'm going to do this thing that I do with my hands under the table, and nobody at the meeting will notice. So be aware of that as well. RRBs don't go away just because you turn 18 and have a driver's license and now a job. They are across the lifespan. And this is one of the biggest myths, is that individuals will grow out of this. A neurodevelopmental difference is across a lifespan. It may mold and take new form and reshape, especially as individuals have it pointed out to them, which is quite negative and can have very negative consequences on how they view themselves. So be very cautious with that. But they can shape and change how they engage in these. And so just know that whereas perhaps a young child at the age of 2 or 3 was lining up toys instead of playing with them, using their imagination, they were lining things up maybe by color or size. And then later on, between age 8 and 12, maybe it was a little different. An RRB was that food could not touch. There could never be sauce or gravy. The foods had to be in their own piles. Don't like corduroy, no tags. And then they became older and evolved into adulthood. And now things were a little bit more subtle, like listening to the same song over and over, or watching the same movie or video over and over on certain days, or as a routine after work because it's just so comforting and enjoyable. So you really have to know how to interview and investigate these things, okay? Because they're not always obvious. They're not always obvious because it's a myth that individuals who are neurodivergent are socially clueless and unaware, and that's something that we have to work to change. And the last thing that I want to mention is this is not talked about as much, but you've heard me mention it a couple times, is all of these things that I've mentioned, RRBs, are not just connected to autism. They can be present in ADHD as well. And folks with ADHD could have tics. So they might have a vocal and a motor movement or sound. And that is actually something that's pretty prevalent and co-occurring. So this is part of the important process of learning assessment so that you can complete a really rigorous differential diagnosis, because it's never yes or no. We're going to do this one test and that will say yes or no if you have this particular diagnosis. That absolutely is not what assessment is. It's looking at history, it's looking at current presentation, how you did historically, academically, socially, familially, where you want to go in the future, what's getting in the way of that, the barriers and repercussions you're experiencing now. It's looking at your medical history in addition to your developmental and academic history, any medications or ailments or surgeries or infections that you currently or historically have had. It's looking at language and how you perform on language assessment. It's looking at executive functioning, sensory processing, motor, all of these areas. That's what goes into assessment. And so the idea that you could just learn 1 or 2 assessments and that's good, that absolutely is not an evaluation. That's completing 1 or 2 assessments. So as you can see, just by learning about RRBs that potentially is an area that you're going to need to rule in or rule out because somebody may come to you thinking that they have OCD, or they come to you thinking, I don't know what's wrong, or one of my friends said I might have anxiety. You're starting to think they have OCD. You work with them for a while, send them off to a prescriber for medication for OCD. And meanwhile, we've only been looking at anxiety and OCD. We've missed the whole potentiality of what might be the bigger picture. And so we do know, again, a lot of co occurring conditions that we can surmise lead us to the need to investigate further in other areas. We also do know there are mimicking conditions that we need to rule in and rule out. And some of these things that are lesser known, like RRBs, restrictive repetitive behaviors, might indeed be part of the picture that you need to assess. All right, so this was a brief mini training, so to speak. It's an opportunity for you to get to know Mindful You a little bit more, maybe learn a little bit more of the terminology, broaden your window of knowledge and what you're looking for when you're working with individuals, and maybe pique your interest about learning more. I encourage you to check out the new online introduction. It's a foundations course, an introduction to ADHD assessment. So this is a very cost-effective independent study course. It is pretty intensive. It provides a lot of information, and it's in no way as in-depth as our other mentored programs. But because we are a social enterprise with a mission of improving information dissemination and the quality of care, less of a top-down approach, but more of a validating and better informed approach to assessment and diagnosis. We're offering this to promote and increase accessibility to knowledge. So check that out. It's only $380, which is unheard of for the information. It's completely online, asynchronous, independent. It doesn't have any of the mentorship or live group coaching, but I encourage you to check it out at the website. That is www.mindfulu.net, and check out the online Intro to ADHD assessment course, and of course, the other offerings. All right, I hope that this was helpful. If you have any questions or curiosities, just reach out. All right, take care and enjoy the information and the assessment freebie that you've received.